Hello, everybody. Thank you for joining us today for our live event, Navigating Provider Directory Accuracy Regulations. Today's event is presented by LexisNexis. Before we launch into the main presentation, I'd like to go over just a few brief housekeeping items. First, today's event will be about an hour long, and we will be recording it. You will receive an email from LexisNexis with a presentation and recording in 48 hours. This is an interactive event. Feel free to submit questions to our speakers using the chat box on your screen. If you would like to enlarge the slides, you may do so by dragging the corner of the box. This function allows you to make them larger or smaller. I'm hoping you can hear me okay, but if you need to make me louder or softer, you can adjust the volume using the media player tool in your console. If you have any technical difficulties during the webinar that I haven't covered, please feel free to reach out using the Q&A box. Finally, at the end of this event, we will present you with a survey. Please take a few minutes to fill it out and let us know your thoughts on today's event. And with that, let me introduce you to today's speakers. Presenting today, we have Josh Scholler, Vice President of Client Engagement for LexisNexis Healthcare. Josh has literally grown up in the data hygiene, data integration, and analytic decisioning space. He works with customers across healthcare to identify and strategize ways to optimize the use, integration, and management of provider and claims data across their broader organizations. Our second presenter today is Tom Sook, Senior Director of Provider Data Solutions for LexisNexis. Tom's responsible for architecting solutions that leverage big data to address compliance, operational efficiency, and process improvement workflows for customers. With that, I'll turn it over to you, Josh.
Thank you, and good afternoon. Thank you, everybody, for joining us. We have three agenda topics today that we're going to cover. First, we will walk through an overview of where the regulations stand. Second, we'll engage in a discussion around the challenge of maintaining provider data. And lastly, we'll explore a proven approach and best practice to managing provider information. So where the rules and regulations stand today. The Affordable Health Care Act specifically addresses the need for increased regulation related to network adequacy and provider directory accuracy. Over the past 2 years, and especially over the past 12 months, the federal requirements have taken shape. As of January 1st, 2016, these are in effect. Furthermore, many state departments of insurance have outlined their own requirements to require payer adherence to the provider directory accuracy requirements. In the following slides, we're going to take a look at the why, what, and who of these regulation applications. So why? The story goes something like this. Consumer X enters an exchange to purchase health insurance. Consumer X wants to select a plan that will enable him or her to continue care with their existing provider. They select a plan that supports this. However, a month down the road, when setting up an appointment, find out that their provider is no longer participating in the plan or is not currently accepting new patients. The consumer is now faced with a choice of out-of-network charges and correlated higher out-of-pocket costs, or in disrupting their care and having to choose a new provider. The goal of these regulations is to avoid this scenario. Anthony Wright of the Health Access California group likened it to this. We don't allow grocery stores to sell products with inaccurate food labeling. We can't have functioning insurance market if consumers don't know what they are buying. And this is real. One major payer has already paid more than $38 million in refunds to affected members. So who is this aimed at? The regulations continue to evolve and in many cases are becoming more and more stringent. CMS requirements are applicable to qualified health plans and standalone dental plans, and they require electronic provider directories be updated monthly. Directories must note whether provider participating in network and is currently accepting new patients. And they also track additional directory elements, including provider name, location, contact information, specialty, and group affiliations. Additionally, for Medicare Advantage, Medicare, Medicaid plans, Section 1876 cost plans, and prescription drug plan sponsors, There are quarterly verification requirements with updates required every 30 days. So why is this such a concern for health plans today? And why do you need to care about it? And really it's because the fines are looking to be very substantial. QHPs and standalone dental plans could face up to $100 per day per beneficiary for problems in their directories. Inaccuracies in Medicare Advantage directories may trigger penalties of up to $25,000 per day per beneficiary, as well as bans on new enrollment and marketing. CMS has plans to start spot audits randomly, or as we have fondly heard out referenced in the market, CMS's secret shopper program. I mentioned in the intro that CMS has requirements, and now these are starting to trickle down to the states. All but 12 states have adopted specific provider directory requirements for at least some type of state health plan. Roughly half of all states specify that updates are necessary, mostly noting the frequency updates must be conducted. In addition to Medicare Advantage plans, 4 states and DC require proactive verification of provider directory elements. And then specific states have either further requirements, such as California's SB 137, which will be effective in July of this year, which requires that the plan investigate any reported inaccuracies within the provider directory within 30 days, and at least annually review and update the entire provider directory by contacting all contracted providers for verification. In addition to those verification, online updates must be made within a week of gathering that information, and paper directories must be updated quarterly. The National Association of Insurance Commissioners, or NAC, is the U.S. standard-setting and regulatory support organization created and governed by the chief insurance regulators from all 50 states. And they released their recommendations in the fourth quarter of 2015 outlining 5 areas. First, electronic provider directories be updated at least monthly. Secondly, plans should consider contacting participating providers who have not submitted a claim within 6 months in order to confirm participation. Third, periodic audit of a sample of the provider directory to verify accuracy. Fourth, directories must note whether the provider is currently accepting new patients. And finally, other provider directory elements must include provider name, location, contact information, provider gender, affiliations, specialty, and languages spoken. While these are generally recommendations, CMS has stated that they will monitor and consider these guidelines as they continue to further define future requirements. We'd like to ask the participants a question. Please select one of the below answers to polling question number 1. How is your organization addressing these new mandates? Are you using an internal solution? Are you currently engaged in working with a solution vendor? Or are you not currently acting and waiting for further clarity on the regulations? Okay. Thank you. The next section, we're going to dive deeper into why this is such a challenge. So provider data is changing all the time. When we look across the universe of providers in the United States, about 2.4% of provider demographics change each month. 30% of doctors change their affiliation each year. And 5% of doctors retire, become deceased, get sanctioned, lose their license on an annual basis. With the changing universe, that's also compounded by the pace of business that payers face. Human errors in data entry coming in on claims or in your inbound channels for provider data information collection, and then also in your siloed collection of that data within the health plans. What the picture shows on the bottom is that if your information was nearly 100% accurate and you didn't have a proactive, ongoing approach to keeping that up to date, in 18 months, 50% of your provider records would contain some error or omission. This really speaks to need for a programmatic approach to keeping this information up to date and highly accurate. To further outline that, you might say, well, how much does the data really change in a week? Across our universe that we track of every single provider, both belly button and doorknob in the United States that can submit healthcare claims and provide healthcare services, we monitor on average 33,000 primary address changes a week, 3,300 name changes, 1,750 phone number changes, and 1,500 fax number changes. Incrementally to that, on the regulatory side, 86,000 state license expirations, 17,000 state license statuses, 7,000 qualifiers, 1,000 DEA numbers. So while the requirements speak of monthly, quarterly, or annual verifications, the universe that we're trying to protect is very dynamic, and in the time we spent on the slide, provider data has gone out to date within your file. So what does that mean for the average health plan? And where does the industry sit today? On average, payers in the U.S. are between 55 and 70% accurate on the critical directory fields outlined in these regulations. Across over 200 network file analyses that we've done over the last 24 months, we have summarized these in the below averages. 8.5% duplicates. Over 23% missing or bad phone numbers. Over 18% of bad addresses or inactive addresses. And then incrementally to the demographics, 2.5% of sanctioned providers and 0.56% retired providers and 0.71% of deceased providers. This is across over 200 health plans. Incrementally to that, since we've kicked off the requirements for verification, in the different areas that we've gone out and validated through our technology and solution, we are seeing between just under 30% and nearly 10% of providers reporting that they are not participating or currently not accepting new patients. So the regulations today are largely aimed at payers to drive compliance, but it really is a two-way street with the providers. Imagine if every health plan in the U.S. called each provider at each location to verify their average 8 to 12 network affiliations on a monthly or quarterly basis. Provider offices would be getting hundreds of calls per month. In our research within the provider community, as we've looked to meet this solution head-on, certain themes have emerged. First, physicians believe it's important that online information be accurate. So while there is administrative burdens that come with this, in order for their patients to find them, they want that information to be up to date. They do have concern over it being inundated with requests for information, so they're looking for the industry to find an efficient approach to the gathering and collection of this verified data. And they have concerns that this is just another administrative item that is going to impact the efficiency of their practice. I'm going to close on the provider data issue with a broader view. We covered the regulations and why this problem is not an easy one to solve. And we talked about why provider data accuracy is hard to achieve. While the cost and investment may seem high, I also want to point out that the ROI can be demonstrative beyond the regulation use case. Provider data quality affects many different areas within a payer's operations. Think of claims operations and the cost associated with manual adjudication versus auto adjudication of claims. Currently, we estimate between 3 and 5% of total claims fallout and manual adjudication is due simply to bad provider information. You then have fraud, waste, and abuse applications, data warehousing and reporting applications, network management and communication, and overall operational inefficiencies. Bad provider data costs the U.S. an estimated $26 billion a year, and these costs were estimated prior to these regulatory requirements being released. So in order to have a positive ROI associated with your initiatives to solve this for compliance reasons, you also need to consider leveraging this event across your enterprise. With that, I'll turn it over to Tom Sook, who will walk through a best practice and holistic approach to provider data management and optimizing provider data accuracy.
Awesome. Thanks, Josh, and good afternoon, everyone on the webinar. So as many of you know who are participating on the call, inaccurate provider directories is a long-standing issue. And really with the compliance demands, the fines are now really just incentivizing payers to clean up things. So what is the best way to fix this problem? I've identified a few tenets here that we believe is a good and effective systematic way to actually meet the compliance issues, as well as, and really more importantly, ensure accurate directories. The first one is baselining your provider directory. And research has shown, and I think even in a recent audit of some plans earlier in November, indicate that at least 25% of provider directory information is incorrect, whether a practice address is incorrect or wrong, or that provider is not accepting new patients under a Medicaid Advantage plan. So it's really important to actually baseline your provider directory. And what I mean by baseline your directory is basically clean your directory for dedupes, purge outdated and obsolete information. Dead physicians are a classic and easy one to identify with. And also, ultimately, assign a persistent ID so that these doctors or these physicians or these providers can be tracked over time, so that when subsequent changes are detected, they can be quickly applied based on tying them to that ID. By getting a baseline information of providers, you really start at a really great level set to then tackle the attestation challenge of really going out and reaching out folks to make sure that they are validating their information. Number two, make it easy for a provider to attest. As Josh mentioned earlier, I know the penalties and the fines and incentives are on the payers to make sure that their directories are right, but in order for this to work, you have to gain provider participation. And a provider will not be happy if it's not easy for them to test information. So I can't emphasize strongly enough that it's got to be a very easy and simple, if that's possible, to allow providers to test this information. One of the ways we think we can do this is by offering multiple channels to which they may prefer to test, and really foster that communication and learn from it, so that continual attestation over time will not be a burden to them. Third, allow a provider to test multiple payers and network plans. This is a fairly significant one. If you take the position of a provider who has to potentially attest their directory information across multiple payers for multiple locations, that could be a time-consuming and a massive approach where they're going to have to literally have someone on staff to attest this information. Our hope is to be able to create a single approach where a provider can be contacted once and then attest for multiple payers, multiple plans at one time. Monitor your directory population. This is critical. I know the mandates have suggested some time frames that attestation needs to be done. Some I've heard is annual, some states are quarterly. We've even heard pleas for monthly. But that's great if you want to do a spot check and a point-in-time attestation. Our goal here, or I think the goal for all payers who have maintained provider directories, is to make sure that it's accurate over time and current. So by monitoring directory population, you can get ahead of the curve versus those mandatory quarterly, monthly requirements by proactively detecting changes, identifying flags that some status has changed, so that your directory is very accurate and up-to-date, and ideally almost in near real-time speeds. And finally, employ the right technology. There's a lot of data to be crunched here, a lot of information that needs to be updated and maintained, and it's really important to have an infrastructure that supports modified big data opportunities, as well as enable real-time updates as they come about. As a leader for solving provider data accuracy solutions for over 10 years, our recommendation is really a 5-component or solution which we envision will ensure high accuracy and maximize cost effectiveness for payers and providers to attest their information. We've seen solutions where single opportunities or single choices to attest are being used. For example, bulk call centers. We're just going to call every provider on the slides on the list just to make sure that a provider is in fact at a certain location, and that brute force call center approach will work. But is that sustainable over time? Is it systematic in a sense that you can learn from the information? Probably not. So a multi-tiered, multi-component solution is one that we're recommending. And those components are the following. Provider data master file, a multi-channel outreach, payer consortium, a provider portal, and leveraging claims data. I'll go into all these 5 sections in a little bit more detail. The payer consortium. If we approach solving this problem as a single payer solution, we will be in for a very expensive and respectfully to our providers, a very annoying solution for our audience. By building a payer consortium, we hope to build and deliver an industry-wide solution that would benefit all payers and providers with a low-cost solution going with a one-to-many approach. Providers will be able to attest their profiles across multiple payers and specific plans, and will be a major time saver and will maximize participation. This is really important because, again, based on our polls of providers and their willingness to attest, the frustration levels that we hear about them potentially attesting for multiple payers, multiple plans, multiple frequencies is overwhelmingly negative. So it's really important that we offer up a one-to-many approach which will be beneficial to all. So I have a poll question here that I hope you guys will all participate on. How willing would your organization be to participating in a consortium? Very likely, possibly, or not at all? To establish a firm baseline of your provider information, your solution needs to be matched and compared to an accurate and updated and comprehensive provider database. Leveraging intelligent business rules, duplicates will be removed, persistent IDs can be assigned, bad data will be corrected, and gaps will be filled. Any changes to a master file can be monitored and compared to your payer directory population so that updates can be pushed out to the payers as they come in. This is very important as it's a very effective proactive way, again, to measure directory and monitor directory accuracy. Your baseline data will also be maintained for accuracy over time. By having a provider data file with ongoing linking, it's sort of like virus protection for your provider data. As you saw in Josh's earlier slide where provider data does degrade over time, by continually measuring and monitoring that directory population, you can be assured that changes, omissions, deletion, gap fills will all be remediated quickly and then disseminated back out to the payer population. As Josh mentioned earlier, providers who do not submit claims within 6 months, it was recommended that they be contacted to confirm participation. We can't agree with that more, and claims is an excellent way to detect and measure or monitor participation within a plan or a network. In addition to the steady streams of claims, we'll allow to monitor providers at locations and correlated billing entities. We can, again, like the master file, alert to new locations and provider changes as we see information come on claims, and ultimately track recency and frequency, a very valuable asset for future analysis and, of course, participation in network plans.
Tom, just to add in on that too, what we're seeing a lot of our customers wanting to do is for providers who are not attesting, go back and validate that against their claim stream. So if this is built into a solution, it allows you to do that in almost a real-time environment associated with the verifications, all within a single solution.
Right, and good point, Josh. Thank you. So when we envision this initial approach, the first time attesting providers will be fairly a manual process. But a more cost-effective and easier solution to capture information will be the use of a web-based portal. This portal will be very specific to regulatory compliance and flexible enough to be dynamically disseminated and display information very specific to each provider's attestation requirements. So, for example, if we have Dr. X who practices at 15 locations with multiple payers, with multiple network plans, we can proactively and dynamically display that specific information for that provider to attest for across all those multiple channels. The portal is a very effective means of capturing that type of information, and we fully expect that providers will probably delegate this task to office managers. So we also want to offer the ability of an office manager or a compliance officer to be able to not only manage the multiple iterations of information for an individual provider, but also to handle and attest multiple providers on the behalf of the organization. We know by experience that a portal is not 100% a solution where most physicians or providers will participate, but we do know it's an important channel for us to have a solution. And along with our multiple data outreach programs, it's another option for a provider to select which vehicle or communication method they prefer to use.
And just to add on to that as well, Tom, I think as plans look to solve this problem, there's going to be a migration and an education period for the providers. And the goal should be to understand channel preference to optimize the overall data capture at the provider level, doing that also with the cost of the verification in mind. So the provider is great. The provider portal is great because it enables a channel that you can start to migrate providers to over time at a lower cost of data capture.
Absolutely. A question was asked about what is a persistent ID. Apologize for that. A persistent ID is something where when we assign a unique identifier to a client, that ID stays with that provider over time. So when changes or updates occur, that ID stays with that individual so that updates and changes and or modifications can be easily measured. Another question popped up was, okay. So moving ahead here, multi-outreach and data capture. Providers have been very specific on preferences and how they want to be contacted. We know by experience that they're very fixated on exactly which method and means to reach out to them. We know that even faxes are still a very prevalent form of communication. Beyond the portal, the solution must be able to support multiple channels to support the provider needs, but also to maximize and be successful on our responses. Our experience that a blend of phone, fax, emails, portals, and even web apps is a great effective means to contact providers and meet their demands on which channel to use. The outreach also enables us to tune and be very proactive in reaching out to our providers when we identify changes or updates within their provider directory information. So if a physician doesn't want to be called at their office or don't prefer to use email, but they want to be alerted by a change or an update by fax, we can support that request with with selections and use of multiple channels to deliver and share information with their provider population. So, I'm sorry, just before we go into this, to summarize, it's just a complete solution to meet regulatory compliance and obtain directory accuracy. It really does need to include a master referential database with linking, a payer consortium, claims feeds, multi-channel outreach, and then lastly, a provider portal.
Tom mentioned we have a lot of questions, so we have time. We'll get into those. I want to close on first thanking everybody for joining today. I hope you all learn more about directory accuracy regulations, the challenges that we face in provider data, and some best practices around proven approaches out there to solve this. I want to close on some final food for thought. Today we focused on directory accuracy, but there's really three legs to the stool in order to have it on firm footing for a health plan. Directory accuracy is often in a push and pull mode with directory accuracy. I opened up that the ACA governs both of those pieces. And to speak more specifically about that, as you go through directory accuracy verification and you have providers that are either not accepting new patients, not participating in the plan, or are unable to get verified, you will have to make decisions about those providers' participation in your plan per the regulations. As you make those decisions, they affect your ability to have an adequate network per some of the other regulations, or in regards to different contracts you have with your employers or state-level requirements. So a solution really needs to look at those two holistically, where as you're evaluating the accuracy and as you're potentially making adjustments to your overall network, you're able to evaluate the adequacy at that same time and be able to leverage broader data assets to do networking to make sure that those two stay in balance. The third leg of the stool is really around your administrative costs and your MLR. And obviously, every percentage of accuracy that you require within your directory has a correlated cost associated with that verification. And as well, recruiting and credentialing of providers to maintain network adequacy has associated administrative costs. So that's really the challenge and the balance that needs to be taken into approach on top of this very specific problem of directory accuracy with your provider information. This isn't really being promoted much in much of the publications that I've seen, but I think it's very important to consider. We wanted to end on that. Thank you again for attending today's webinar, and now we'll open this up for Q&A via the chat function. So the first question, how would you construct a persistent provider ID separate from MPI or tax ID? Or would it be some combination of the two? LexisNexis has built a solution both around master member ID as well as provider ID built on the aggregation of thousands of sources of data. The industry standard numbers that are out there, such as tax ID, which is a many-to-many, a provider can have many tax IDs, and a tax ID can be linked to many providers, really don't work that well. And the issues with NPI as a single ID is that it only is associated with a single practice location for a provider. And currently the NPI file is about 70%, a little less than 70% accurate at the provider at location level, making it very difficult to crosswalk or count on as an ID. What we believe is that through the combination, we bring together over 2,000 sources of data and have history on the providers dating back to the 2005, 2006, which enables us to create a comprehensive profile of a provider, all of their active and inactive locations, all of their state license, NPI, DEA, NPI, tax ID associations, and allows us to utilize a mathematical and probabilistic matching approach to creating a unique ID. So we have a proprietary ID process that enables us to do that unique provider ID, and we utilize a similar philosophy on the member side.
Okay, I'll take the second question. Does the CMS regulations apply to dental networks? And the answer is yes. Standalone dental plans are going to be required to do this attestation. And Josh, I'll read the question. Do you foresee an extension of provider data access to other CMS concerns, for example, validating both providers and network adequacy?
I think I preempted that question with our closing. I do, and in fact the ACA does cover requirements for both. I think with the exchanges being turned on and then having the backlash of consumers going to the AG's office with out-of-network costs raised the directory accuracy in its visibility in the media and thus in the regulation hierarchy. But I believe network adequacy is directly linked and will also be seeing incremental requirements around that.
Yeah, absolutely. It's going to be immediate follow-up. Josh, next question. How do carriers currently get information for provider directories? Is there any responsibility placed on the provider?
It's an interesting question. Providers have just an inert desire to have information correct in the directories because it's how patients find them, and that's how they grow their practice and make income. That being said, notoriously, provider communities have not been great at updating their information, and it's been difficult. There is certain legislation, I believe there's been some proposed in California, around health plans' ability to eliminate providers from their network, as well as withhold claims payment for their inability to verify their information in compliance with these regulations. However, the majority of the onus is still on the payer today.
Absolutely.
Do you have anything to add?
No, I think that's right. I can answer this next one. So the question is, has Lexis identified existing sources for data elements of the master file, or are you proposing to build this with data supplied by payers? That's actually an excellent question, and if you read our presentation, you might assume that we are proactively building our master file through payers. To answer your question, we actually already have an existing master file. It composes of over 2,000 sources. Our philosophy is to pull information directly from the authority sources for that information. So we will not pull state license information from a third-party aggregator. We'll go directly for the state boards and so forth. Respectfully to all our payers out there with the directories, we know they're bad. So again, we don't want to actually be harvesting that information, but we will identify opportunities to do some checking on our own. For example, if we do see a new practice location that we've never seen, we might actually queue that up to verify if that exists. Again, to obviously attest the information on the behalf, but that's potentially some learning into our database. So we come into this opportunity with an existing provider master file. Let's see here.
I can take this one.
Okay.
There was a question, is the per month fine, is it just for the members affected or the whole population? For the exchange piece of the $100 per day, it's affected beneficiary, assuming for those who report problems. So it's related to the affected. I haven't seen regulation on the other side on the 25,000, but given that the magnitude of the differences that govern those two pieces, I'm going to make an educated assertion that it is also based on the affected beneficiary, but we'll follow up on that. What is the key hurdle preventing the deployment of a multi-payer provider portal for physicians to update their data? I think it's a segmented industry is part of the problem, and I think that it's payer-driven as part of the problem. So, one, there's several industry standard portals that are out there. Some of those are communication portals. Some of those are claims portals. Some of those are credentialing portals. And they all meet a niche, but they're not universally utilized today. So as these portals are tried to leverage for this, it doesn't create an ecosystem that is leverageable enough across the full industry. We'll see over time how that evolves. The other issue is that almost all of those portals are payer-driven. And what we're trying to get is something that the providers are really actively utilizing and engaged with, and is provider-centric in that it's very simple for the provider. Thinking things like single sign-on from the provider's current login to their payer sites and things like that. So we don't send them around and makes it easier for them to use, as well as having key functionality like autofill. So a provider can very simply go out. We already know what the answers to their network affiliation across plans are. We can autofill that information, and it allows the provider to simply click, yes, this is all correct, to get that verification, versus serving up forms that take minutes, if not hours, to get completed to fill all that information in.
Is your interpretation that paper-based provider directories also need to be updated monthly? We do, so I can answer this, Josh. I think we've seen that the regulations for updating paper isn't as frequent as it is to update on a URL or website. The last I saw, it was changed to biannually, but we can follow up on the specifics of that. But it's definitely a little less frequent than what's required on a provider directory website.
For California SB 137, they have mandated paper directories on a quarterly basis.
Quarterly basis, okay.
How are health plans operationalizing the attestation process with providers? I think there's many different approaches that are out there. The most common that we've seen is that taking the brute force approach, which is putting together an army of callers and going out and trying to get this verification done to build compliance. That approach is the most costly. It doesn't optimize the overall capture rate of the data. It's the most obtrusive to providers and therefore not sustainable. But I think by and large right now, given the requirements just came into effect, that's what we're seeing on the bulk. There's different pilot programs and different trials and tests that are going out there on the industry. I think we're one of the few areas that have been doing provider data management for the last decade and have more of this service in place.
What if there are additional attributes in our directory? For example, access to public transit, office URL websites, etc. That's an excellent question. And we've actually, as we started solving for this problem, have recognized that there are definitely nuances across states, across payers' interpretation of what they want to attest. So our portal actually is flexible and dynamic, built based on the payer's requirements, and flexible enough to render information on the website per specifications and configurations set up by our team and mapped back to this very specific state and payer plans. The public transit question is actually a very legitimate one because we know that we've heard that from the California side. So very specifically on that specific question, we do actually have that built out today. Let's see.
The focus here was on provider directories, but last year's CMS webinar in the fall, CMS stated their expected updates to pharmacy directories in the same time frame. As well, do you have thoughts on how transferable these suggestions are for that directory? Yeah, specifically CMS said on the Medicare Advantage, Medicare, Medicaid plans, Section 1876 cost plans, and prescription drug plan sponsors, that these requirements, that they're requiring updates to directories at least every 30 days and with quarterly outreach for the contracted providers. We see this technology and approach to be directly applicable to that. Depending on the participation in the prescription drug plan, it will require incremental contribution of that detailed data from the entity that needs that verified, but the same process, multi-channel verification, portal, monitoring, all applied to getting this done in an efficient and effective way.
It must be difficult to solve for such a dynamic CMS environment. How do you prepare for the possibility that a new reg is issued? So new regs, and this is a very hot topic, we've seen and been modifying and making our solutions as dynamic and nimble as possible. For example, we know that in February there will be some updates on the insurance board. We're just trying to keep up with the demand. We're taking a conservative approach. Hopefully that the regulations seem to be loosening in terms of the mandates and the strictness and the time to actually attest. So it is actually a very difficult thing. Anyone in systems and development know that that's always a moving topic. But we are, again, building for the conservative with the capability of being flexible to potentially loosen or add additional fields.
The only thing I'd add to that, Tom, is that I think this is a good question for compliance departments within the health plans to ask themselves. What is it going to take to stay on top of that, and what is your, how do you want to manage that risk? Part of a lot of the solution providers that are out there should maintain that they will do the monitoring of the regulations and make sure that you are in compliance as part of their solution. We have legal teams, we have compliance teams that are monitoring both the state and federal level and feeding that into our products, so we're staying one step ahead of that. And as a solution that's leveraged across the industry, it enables us to deploy resources to do that in a very focused way, whereas a health plan would need to probably create that discipline. In trying to move away from payer-driven to provider-centric, how are network affiliations known? Where does the information come from? Are they reported by the provider, confirmed by the payer? So in the scenario today, as part of the contributory concept that Tom described, the payer is contributing the networks that they need to have verified. We are looking at different approaches where we can look at the actual state exchanges or federal exchanges so that we can get broader verification done at those single points. But right now, the consortium is who's contributing that network level detail that they know that they need to have the data verified at. We're then compiling that, utilizing our unique provider ID to aggregate those across the different plans for each of their verifications, and then optimizing that across plans for the outreach, again, with the goal of optimizing data capture, optimizing quality, and doing it in the most efficient and cost-effective way.
How would one go about forming and or joining a provider consortium?
So yeah, for ours, it's part of the service that we offer. So when we go out to market and we work with customers to provide these services, the consortium is a part of that service and is defined contractually as a part of that service. There's different layers to the contribution based on the level of service that you would be utilizing. So the basic provider data cleansing might require basic network data from a contribution perspective. If you're going to do the verification of the network requirements, it requires the network data. And then a lot of our clients are contributing their claims data as well so that we can offer the claims monitoring as well as the ongoing verification of the provider's location based on claims activity that we see. And we've built out that infrastructure to do it. Today we monitor about 1.2 billion claims on an annual basis in that nature. So those are the three areas of contribution, and it's just a basic part of our service.
So, and I think this will be our last question here. So the question, are you saying that a new consortium be created by the payers by us reaching out to one another? Or are you saying that you have already created one or can create one through your various current clients?
So we've already created one, but we're trying to grow in its comprehensiveness. Today we have about 60 health plans that do contributions to our master provider referential database, including 8 of the top 10. That does not cover all of the attributes that we talked to today for provider directory accuracy, so those are being added to. So we have those. There are other, at the government level, contributory databases as well. I'm not aware if there's other solutions on the market that they exist, but I think there's the actual physical data consortium, which is part of the question. The other is the philosophical approach to the payer community, and they're banding together to solve this as an industry problem. And one of our poll questions was really aimed at that. If you believe that this is for the betterment of the industry and does not violate any competitive or differentiation from the health plans, which is our position, especially since we black box network level detail from any plan to plan association, and the results are only shared with the specifics of that plan. A consortium really allows you to leverage the requirements broadly across the industry, and we really see it's the only way that sustainability will occur correlated to these requirements, meaning from a cost perspective as well as from a provider intrusion perspective.
Is CAQH one source of data you are gathering? It is not a source of our master file today. Another question here. Does LexisNexis have a strong provider data model for storing, sorry, the question popped up and scrolled. For storing and mapping multiple multi-tiered providers or network groups, or we don't have a good data architecture for that yet, so data is not properly stored and retrieved?
Yeah, I think that that's a common industry problem and something that we've spent a lot of time over the last 11, 12 years building out, which is being able to collect and store the information at multiple levels. I think several solutions out there on the market today are good at collecting provider-level information. That's not going to meet these requirements. There's some that enable you to collect provider at location level. That's not enough for these requirements.
Absolutely.
Our data model is very flexible. It allows provider at location TIN, provider at location network affiliation, all those different many-to-many and many-to-one relationships within our data model. And then specific to the requirements for directory accuracy, we've also built out the autofill data capture that is dynamic associated with that level of capture.
Yeah.
So in other words, we see these requirements growing beyond HCPs to facility level.
That's right.
And the different many-to-many within that, and we need to be able to capture and collect that. One of the other things that we didn't talk a lot about today is the audit requirement. So as we talked about CMS coming in and starting to do random spot audits, a health plan is going to get questioned on some of the results. And you need to have the ability to instantaneously pull back your verification detail, whether that be a PDF of a fax, whether that be a phone, recorded phone call, whether that be a entry into a provider portal. All of that needs to be collected and on instant recall. So that's got to be a piece of the solution as well.
Does LexisNexis provide data validation services in addition to matching provider records, call centers? The answer is yes. The solution that we have to do systematic provider validation, that's something we have in place today by sending information through batch or real-time files to us. But we have a fairly substantial sized outreach program, consists over 200 individuals who do custom campaigns on the behalf of our clients to do specific validation campaigns.
There was a question, do the regulations apply to self-insured RISA plans? Today, our understanding, interpretation is that does not apply to self-insured.
Would you allow groups the opportunity to confirm multiple providers at one time by location if going through a consortium? The answer is yes. In fact, that's a strategic strategy of ours and objective to be able to enable the one-to-many type attestation.
Are plans currently only pushing data to you? Are any plans currently integrated with your database to pull updates directly into your system? So both are enabled. We do real-time API checks into the database. We do ongoing where we house customer-specific network information that enables us to do real-time monitoring and then alerts. So it's not just a push, it's also gives the plans the ability to not only push data to us, but us to push notifications back to the plans.
Hey.
I'm not seeing any other questions. There's one. If a provider runs their own PPO network, are they required to perform? I just got, sorry. I lost that one.
Yeah. Okay.
We'll conclude today's webinar. These were great questions. We really appreciate everyone's participation and the great questions. There is contact information, and as was stated in the beginning, everybody will get a recap and a copy of the presentation deck, but we would be glad to follow up with any additional questions. Thank you very much.
Thank you.